Okay, great. Hello, everyone. Thank you so much for joining us for NAMI Maryland's 40th annual conference. My name is JB Moore, and I am a volunteer with NAMI Maryland. I will be your moderator for this session today. This workshop session is PTSD Prevention for Individuals with Psychosis-Related Disorders, presented by Tiffany Beeson from the University of Maryland, Baltimore County, Gloria Reeves from the University of Maryland, and Malka Dubin from CBT Baltimore. And I hope I pronounced your name correctly. You can read more about our amazing presenters, including their full bios, in the digital conference program on the official conference website. Individuals with psychotic illness and their family members may benefit from emergency or crisis mental health clinical services. But unfortunately, these services could also be experienced as traumatic. For example, involuntary hospitalization, seclusions, restraints, etc. In this workshop, we will review symptoms of trauma, PTSD, common developmental risk factors for PTSD among individuals with psychosis, and challenges that patients and families report about crisis service utilization. We will also introduce emerging PTSD prevention strategies. Our interactive discussion will focus on identifying unmet patient family needs related to PTSD prevention during crisis care episodes to help guide future intervention work. If this is not the workshop you meant to attend, please click the back button on our browser or click the sessions button on the left-hand side of your screen to return to the full list of workshops we have available. We will be addressing questions at the end of the presentation. If you have any questions as the presentation continues, please post them in the Q&A on the right-hand side of your screen. We will be reviewing questions as they come in, and if something in particular is unclear or needs to be expanded, we'll ask the presenters after their presentation has concluded. We are pleased to offer closed captioning for this year's conference. Captioning is only available for attendees using a desktop. To enable captioning, please click on the 2 capital C's icon below the display of our presenters at the bottom of your screen. Once you click the icon, the video displays will become smaller and you will see the captions being generated underneath. If you have any comments, concerns, or technical issues, please post them to our chat and our technical assistant will address them accordingly. I'd now like to welcome our presenters for today's workshop, Tiffany Beeson, Gloria Reeves, and Malka Dubin. Thank you so much for joining us today.
Thank you for that introduction, JB, and thank you to my co-presenters and the audience for participating in this talk and this learning session today on PTSD prevention with individuals with adverse experiences with crisis care for psychosis. As JB mentioned, my name is Tiffany Beeson, and I am an assistant professor at the University of Maryland School of Medicine. And I'm grateful to be presenting on this topic today with my colleagues that I will invite in a moment to come off mute and share a bit about themselves. And just to share a little bit more about myself, I am a clinical and community psychologist, and I have primarily worked with children, adolescents, and families, providing generalist services as well as trauma-focused treatments in school systems. And I currently work as faculty at the National Center for School Mental Health and the National Center for Safe Supportive Schools. And I focus on training K-12 educators and school-based mental health clinicians on how to provide culturally responsive and trauma-informed supports. And I'm so grateful and honored to be working with my colleagues today who are going to be sharing on this topic, who have expertise in psychosis and work with folks who are impacted by psychosis spectrum disorders. And we are aiming toward developing PTSD prevention interventions for folks who have psychosis spectrum disorders. And we are so happy to have you all here today, many of you who are researchers and clinicians, educators, and folks with lived experience, whether it be your own experience or an experience of a loved one impacted by trauma and or psychosis, so that you can share your reflections on suggestions on how we can better meet the needs of folks impacted by psychosis and trauma through interventions. All right. So before we get into the content, I always like to take a moment to stop and engage folks in community connector activities. So for everyone on the hop-in, I ask that you please share in the chat box your name, if you will, and if you would also share your role or organization or connection to NAMI. And then also share with us, what is one activity that you do or that you will do to be well during this fall season? How are you falling into wellness this fall season? And I am going to call on one of my co-presenters to call out how folks are falling into wellness during this season, as I can't see the chat box. And I can start sharing while our attendees are reflecting. So one thing that I'm doing this fall to be well is getting outside and being mindful of all of the beautiful fall colors and spending time with family. And I also want to invite my co-presenters to introduce yourselves and a fall activity, a fall wellness activity that you're engaging in. And I guess we can go in order of Pamela, Malka, and Gloria.
That's great because fall is my favorite season. So I love to share all of my fall wellness tips. I'm Pamela Rakshan Rakhtar. I am an assistant research scientist at UMBC. And I'm a co-presenter here today and was honored to present earlier this morning. And my one favorite activity, I actually do this year round, but it's particularly enjoyable in the fall, is I get a really hot cup of coffee or tea in the morning, and I either read a book or listen to a podcast or do something that's like a fun activity that's totally unrelated to work or taking care of folks or doing chores. And it's a nice kind of moment to center myself.
Hi, my name is Malka. I'm a clinical mental health counselor. I work as a therapist at CBT Baltimore, and recently have been assisting with some research at the University of Maryland. My areas of expertise, or my specialties, really are anxiety spectrum disorders, such as generalized anxiety disorder, social anxiety disorder, and OCD. And while the field of psychosis, the study of psychosis, is a little bit newer for me, I am really looking forward to sharing what we've put together for this presentation. In terms of a fall wellness activity that I've been doing, I've been trying to incorporate all those yummy fall vegetables into my cooking, like squashes and pumpkins, and we've created some really delicious soups. So it's been, I really enjoy this season as well.
Hi, everybody. My name is Gloria Reeves, and I'm just looking in the chat, and it looks like we have a lot of people who share the passion for the fall season, and a lot of uber healthy people who run and walk and spend a lot of time outdoors. I don't know if watching football is considered a wellness activity. Usually my blood pressure spikes because I'm a Washington fan and they're not doing well, but that is my thing. It's really great to spend some time with you. I'm a psychiatrist by training, and I do, like most people at a university, I do research and see patients and teach, and really interested in this topic today and to learn from folks in the audience. I work in a hospital setting, so there's definitely room for improvement, especially over the pandemic, and how we support each other, not just the patients that we treat, but also their families and our staff, our folks on the front line. So thank you.
All right. Thanks for those introductions and sharing your fall wellness activities. Just as a reminder for our objectives today, we're going to be talking about some common symptoms of PTSD, risk and resilience factors related to PTSD and psychosis, and some of the challenges that families and folks impacted by psychosis spectrum disorders have expressed related to crisis service utilization. We will discuss some emerging strategies for PTSD prevention for this population. And we hope to engage you all in active conversation during this talk. So we have some slides that we're presenting some information to you about, and we want to hear from you, as the next slide says, about your reflections on how we can prevent PTSD for folks impacted by psychosis spectrum disorders. I wanted to lift up some shared agreements on how we will use this space and time that we have today to speak on this topic. And I invite everyone to stay engaged and share your ideas. And also to respect confidentiality. It's my understanding that the sessions are recorded and later posted to the NAMI website. And so I just ask, if you are disclosing information about experiences, especially those that are different from your own, that you're mindful not to share identifying information about folks. And also, when we are talking about trauma, and we will be careful to talk about the topic of trauma at a high level and avoid describing graphic details of traumatic experiences, just to be mindful of the needs, especially of folks who are trauma survivors. Our intention is to not re-traumatize or trigger folks by sharing too graphic of details. And related to that, I invite everyone to show compassion to yourself and others. Sometimes when we have conversations about the distress that folks who are impacted by trauma and psychosis experience, it can be hard to sit with that distress. So I invite you to do whatever you need to do to be well while we engage in this talk and conversation. And if everyone could please indicate that they agree to these shared agreements by saying yes or nodding or giving us a thumbs up, that would be great. And I can't see you, but I'm feeling the thumbs up. I'm feeling that everyone agrees to these shared agreements. So
yes, lots of folks saying yes, thumbs up, and great participation in the chat. So thanks, folks.
Awesome. Thank you. All right, here's a prompt for the audience. And we're going to have these interspersed throughout the talk because, again, we don't want to just talk at you. We value your experiences and your expertise and opinions. So our first prompt for the audience is to name one word to describe the crisis care or hospitalization experience for individuals with psychosis. From your own experience as a person with lived experience, or a provider, an educator, community member, what's one word that you would use to describe the crisis care or hospitalization experience for individuals with psychosis? Please put those reflections in the chat box, and I'll rely on my co-presenters to share what folks are reflecting.
So I hear essential, but far from ideal. It's the first thing shared in our chat.
Thank you for getting us started with the reflections. What are some other words that folks would use to describe the crisis care experience? And if it's too challenging just to use one word, a short phrase is acceptable as well. And I think essential but challenging is a really kind of complete and brief description of the experience for many folks impacted by psychosis who experience crisis care or hospitalization. Unless there's additional comments coming in, I can move on to the next slide.
We have a few folks coming in saying grief exhausting as well.
Thank you all for sharing. So related to these reflections on how the crisis care experience is experienced, is challenging and essential, we wanted to take a moment to reflect on some of the benefits of hospitalization for folks with psychosis spectrum disorders, as well as the potential challenges. And I am going to pass the mic over to my colleague, Dr. Gloria Reeves, to present on this topic.
Yeah, thank you so much, Tiffany. And I appreciate the comments about describing hospitalization, grief, exhaustion. We had a parent group earlier in the week, and a parent used the word roller coaster. A lot of highs and a lot of lows with a very intense kind of time. And I think for those of us who have experienced a hospitalization ourselves or have a loved one that we're close to, having that access to a hospital in some ways can be extremely beneficial. We think of it as that's your safety net for care. So that's a place to go where there's a really opportunity for very close monitoring, especially if you're concerned about any safety issues like self-harm behaviors. It's an opportunity to really accelerate an evaluation because the person is observed day and night and by a team of specialists. And there's an opportunity to kind of jumpstart treatment and hopefully get folks connected to the resources and the referral sources that they need. But we know, as our expert mentioned on the chat, it's far from ideal. And I will say I'm a mom of an 18-year-old, and never forget the moment of being told, oh, you're not allowed to come in during an appointment, or you're not allowed to talk to the team without your daughter's permission. And there's a lot of challenges when you're a loved one, and then also, of course, when you're a patient going through a really difficult time, that it may be because of safety concerns that you have things done that are quite invasive, like giving medication when you don't want a medication, restraints, being asked to be in a locked room. For our young adults that we treat, the biggest thing you could do to them is remove their cell phone from them, and that separation is pretty stressful. And that we know that hospitals are really short-term acute crisis stabilization. So it's not ending up with a place of great wellness often, but just sort of getting a calmer situation and then moving towards solutions. So we know that there's a lot of benefits of hospitalizations, but there's a lot of limitations to it as well.
Thank you for sharing that. Sorry, I think I may have interrupted someone. Or all good? Okay. Thank you for sharing that balanced perspective, Gloria. All of those points resonate really well with me, given my positionality as a person who have very close loved ones who have psychosis spectrum disorders, really understanding for myself and my family how hospitalization is an essential part of care sometimes for my loved ones, but also holding on to the exhaustion and the grief that folks were sharing about a bit earlier too, as it relates to that experience, as sometimes it can be experienced by folks as traumatic, including my loved ones. And that segues into our next thing that we wanted to highlight is research that a group of researchers, Liu et al. In 2017, conducted, where they interviewed folks impacted by psychosis spectrum disorders about their experience with crisis care. And folks were acknowledging that there are several aspects of crisis care or hospitalization that are traumatic, that are experienced as traumatic. And there were 5 major themes of traumatic aspects of crisis care reported by patients with psychosis, including long hospital stays, which can impact a person's connection to their family and loved ones and can have impacts on employment, and medication side effects were named, as well as coercive treatments like involuntary hospitalization, the use of restraints and forced medication, being with other patients. So being with other folks who are experiencing psychosis symptoms, hallucinations, and delusions that can be scary for them and those around them. And then they also named mistreatment by professionals when they were receiving crisis care. So these are aspects of the crisis care experience that folks have reported. Oh, and I did want to mention, related to this slide, this is kind of part of the catalyst for our interest in developing PTSD preventions for folks impacted by psychosis. given our awareness that part of the symptoms of psychosis spectrum disorders, as well as the experiences with crisis care sometimes can be experienced as traumatic. So this population in particular is at increased risk for developing PTSD, which underlies the importance of increasing the number of PTSD prevention programs for this population.
And Tiffany, if I could just mention very quickly that I think for all of us who've experienced hospital care in one form or another over the pandemic, just the things we used to take for granted about being able to visit your loved one in person, and to be able to feel like hospitals are a safe place, physically safe place, that you're not going to get illness, that's an added layer that a lot of families and patients have been dealing with.
Yes, thank you for adding that point, Gloria. Very true. So what is trauma? I like to use this universal and simple definition of trauma to remind or educate audiences about what we mean when we use the word trauma. And it's called the 3 E's of trauma. And so first, an individual experiences a painful or distressing event. And there are a wide range of types of events that individuals can experience. And however, the event alone is not enough to meet the definition of trauma. For the second E, the individual will experience an intense and prolonged stress response as a result of the event. And they may feel terrified during the event, and the stress response continues long after the event has ended. It's also important to note that different individuals will have different responses to different events. And individuals can experience the same event, but not necessarily all experience those as traumas. And some people will be more resilient than others in response to the same experiences, more or less. And then the final E of trauma is the event and the individual's experience of the event produces effects, the third E, that lasts beyond the immediate aftermath of the experience. It's very common for someone to experience an acute distress response in the first 2 to 3 months after something stressful has occurred. And these symptoms often go away with support and over time. However, physical and emotional symptoms that last beyond the period or that period of 2 to 3 months are signs that the person is experiencing ongoing distress and needs additional support. I just wanted to make a quick note about the prevalence of PTSD or trauma and PTSD. So within the general population, estimates range in terms of exposure to trauma. So 40 to 80% of people in the general population are exposed to trauma over their lifetime. And about 6 to 9 people will experience PTSD over their lifetime. And I wanted to highlight this difference, this big difference in the level of exposure versus development of PTSD. It just is evidence for the fact that human beings are very resilient. And so just because we experience trauma doesn't mean that we will develop PTSD. In fact, most people will bounce back, so to speak, from trauma. And then among people with psychosis spectrum disorders, there's an even higher rate or prevalence of trauma. So somewhere between 12 to 16% of folks with psychosis have PTSD symptoms or diagnosis. And psychotic symptoms are present in about 15 to 64% of people with PTSD. And I wanted to note that these ranges exist because these numbers are pulled from different studies that look at these factors in different populations. And so there's a range. All right. So now I am going to pass the mic to my colleague, Malka Dubin, to talk about some of the adverse reactions to trauma and PTSD symptoms.
Thank you, Tiffany. So I think this connects really well to your E of effects, like these symptoms that we're going to talk about are some of the effects that someone might experience after a traumatic experience. These are symptoms that are listed in the DSM-5, and they are the most common symptoms of an adverse reaction to trauma. There are others, but these are the ones that are most commonly seen. So the first is intrusive thoughts or memories. So if someone has been involuntarily restrained during a hospital experience, their adverse reaction to trauma could be having these nightmares of like being physically restrained. Avoidance of people, places, or experiences that are reminders of the trauma. So again, going back to the example of an aversive hospitalization experience, someone might then avoid going to doctors or going to a hospital. Another adverse reaction to trauma can be negative changes in thoughts or mood related to the traumatic event. So for example, a belief about the world that the world is a really dangerous place that stems from having had that traumatic experience that felt very dangerous and very threatening. And lastly, are changes in emotional and physical reactions. So someone who is having an adverse reaction to trauma or experiencing symptoms of PTSD might be constantly looking over their shoulder, kind of that hypervigilance, constantly looking around and looking out for danger.
Thank you, Malka.
Sure.
So those are the common reactions to trauma that are aligned with PTSD's symptoms. And now I wanted to highlight the fact that there are several factors that can increase an individual's risk for developing PTSD after exposure to trauma, including experiencing intense or long-lasting trauma, as well as the experience of adversity in childhood. So adverse childhood experiences and or just early trauma exposure can increase a person's risk for later developing PTSD, as well as certain jobs. So having a job where there is risk of exposure to traumatic events like military personnel and first responders, that exposure to very frightening and scary situations and danger increases risk for PTSD, as well as having other mental health conditions like depression and substance use disorders. Additionally, lacking social support. So one factor that often helps people be resilient and bounce back from trauma is having social support or folks around them and resources around them to help them cope and recover. And so lacking social support is a risk factor. And then finally, having blood relatives with mental health conditions. There is about a 30 to 40% heritability estimate that 30 to 40% is the heritability estimate for PTSD risk. So having blood relatives with this condition or other mental health conditions can increase a person's risk for development of PTSD. PTSD risk is also associated with certain social determinants of health. For those who may not already be aware, social determinants of health refers to the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. And there are several social determinants of health-related factors that are associated with increased PTSD risk because they simply increase an individual's or a community's risk of experiencing adversity, including poverty. So not having enough food or not having a roof over your head or experiencing homelessness or problems with unemployment, as well as sexism, racism, heterosexism, cisnormativity, and all of the isms and forms of oppression, and natural disasters, as well as political oppression and discrimination. So I just wanted to highlight, related to this point of exposure to oppression as a risk factor for PTSD, I just wanted to note that the experience of racism and all of these forms of oppression is traumatic and can be traumatic for individuals and whole communities. And so all of the effort that we do to increase trauma-informed supports and address these various forms of oppression can reduce the prevalence of PTSD in these populations. So you can't talk about trauma if you're not going to also talk about and highlight resilience. So what is resilience? Resilience can be defined as the process of adapting well in the face of adversity, trauma, tragedy, or threats, or significant sources of stress. And that could be racism and other forms of oppression, and or family and relationship problems, health problems, workplace and financial stressors. So all of the things that we do to be well in the face of those adversities. And as it relates to the development of resilience, I really like this graphic that shows a fulcrum or a seesaw, if you will. It's from the Harvard University Center of the Developing Child, and it helps us think about the development of resilience with negative outcomes on one end of the seesaw and positive outcomes on the other end. And if we can think about trauma and adversity contributing to negative outcomes, and then coping skills and resources and supports contributing to positive outcomes, all of those factors help kind of tilt the seesaw towards those supports, help tilt the seesaw to the positive outcomes. And that's how resilience is made evident or happens. All right, now I have a question for the audience. What is one factor that can promote resilience for people with psychosis and or their families and loved ones? Please share your reflection in the chat box about one factor that you are aware of or may have even experienced or noted in folks that you support through your clinical service. One factor that can promote resilience for people with psychosis and or their families and loved ones. And I'll ask my co-presenters to yell out some responses.
Well, I can jump out. One thing that I shared was peer support and friends. Other folks said supportive friends and networks, having someone to talk to, whether it's a professional or community resource, empathy.
Awesome. Thank you for sharing those factors that promote resilience. I love talking about resilience because those supports are important to resilience. And I have a slide here that shares more about PTSD resilience and protective factors. And folks named many of these. So help-seeking behaviors can be very protective for individuals from the development of PTSD, even when exposed to trauma and adversity. So looking for help from loved ones or help seeking out a therapist or a clinician. Finding a support group after the traumatic event. Learning to feel good about one's own actions in the face of danger. So there's a lot of literature that talks about the way that people develop narratives around their trauma. And especially when we have a narrative or develop a narrative around our own actions in surviving the trauma, that can help be protective against developing PTSD, as well as having helpful coping skills, like talking about your challenges with loved ones. Some folks utilize spirituality or religious practices in order to cope from trauma. And then being able to act and respond effectively despite feeling fear when faced with adversity or trauma. All right, so now we're going to talk a little bit more about how trauma relates to the experience of psychosis and psychosis spectrum disorders like schizophrenia, delusional disorder, schizoaffective disorder, and other conditions that have psychotic features. So there is a reciprocal or kind of back and forth relationship between trauma and psychosis. So as I alluded to before, trauma can lead to PTSD, and there is an increased risk of psychosis among folks who are exposed to trauma. And then kind of conversely, psychosis symptoms such as hallucinations or delusions, as well as treatment for psychosis, specifically crisis care treatment, can be traumatic, which can then worsen a person's overall clinical presentation. So worsen their trauma, psychosis, and other mental health conditions or symptoms. So there is a back and forth relationship between trauma and psychosis. where we're seeing trauma being a risk factor for psychosis, and then the experience of psychosis and its treatment as a risk factor for developing PTSD. Very complicated and nuanced relationship. So this slide kind of outlines some of the common experience for folks impacted by psychosis spectrum disorders that can be experienced as traumatic, including having frightening hallucinations. And then after the general experience are some quotes that were pulled from a research article that involved folks with psychosis kind of sharing about their experience. So voices telling me something bad is going to happen, or suicidal thoughts or attempts, wanting to die, thoughts or attempts to hurt others, as well as paranoia or delusional thinking. So fears about going to jail or people trying to poison oneself, and bizarre or disorganized behavior or catatonia. One person reported post-traumatic reactions to feeling like they couldn't walk or talk, and that was traumatic for them. All right, so now I'm going to turn the mic back over to my colleague Malka to discuss what factors increase risk for a person with psychosis developing PTSD or adverse reactions to trauma.
Thank you. Yeah, so as you said, there are some risk factors that can make it more likely for someone to develop PTSD after the experience of psychosis. So one risk factor is having a previous trauma history. So someone with any of the ACEs, adversive childhood experiences, any kind of severe injury, near-death experience, et cetera. All of those things can put someone at increased risk for the development of PTSD following psychosis. Also, individuals who experience intense emotional reactions and disassociation during the psychotic episode. So, if someone has particularly violent or aggressive kind of psychotic experiences, and that's a very emotionally distressing way to feel, they are more likely to develop PTSD. And like we talked about before, social support is really important for anyone who is struggling, but specifically people who have experienced psychosis in any way. To have the social support following that experience can help reduce the risk of developing PTSD following the episode.
Thanks, Malka. And I'll move on to talk about some of the challenges that folks who are caregivers or family members of those who are impacted by psychosis and trauma. So chronic stress, helplessness and loss of control, guilt, grief. In my own experience with loved ones who have psychosis, I definitely experienced some grief related to coming to terms with a new understanding of who they are after their diagnosis, and then low self-esteem, our own health challenges, vicarious trauma. So witnessing your loved one experience symptoms that are traumatic can be very challenging for caregivers and families, as well as the fact that for psychosis treatment for adults, for many adults, they can opt not to involve their families and loved ones into the treatment process, and that can be challenging for caregivers and family members. And I'm going to ask Gloria to share a little bit about the challenges for hospital staff who treat folks with psychosis.
Yeah, thank you, Tiffany. So I think hospital staff, especially over the pandemic, has been really challenged because we've had a lot of turnover. There's a lot of workforce shortages. And so there's sort of the baseline level of stress seems much higher than what I recall from pre-pandemic years. So I think that kind of colors everything. And we need to do better at thinking about how to support that workforce so that they can provide better care to patients, and also making sure that we're maintaining our high quality standards. So I know there's been a lot of efforts by health systems to look at those issues. But we know that when you have an experience with a patient who is unpredictable and perhaps aggressive, or you're worried they're going to hurt themselves, that level of stress, if the person doesn't have the support they need of a team to help manage those concerns, can impact their interaction with patients and with future patients. So we know, we've learned in our hospital system really the importance of training, ongoing training, not assuming just because somebody's a veteran that they don't need retraining, re-support, and also thinking about the support of the team. And we know that in hospital care, people differ in how well they can engage a specific, unique individual. Everybody's different in who they connect with. And so thinking about how to utilize the support of the team and working together if you're having trouble engaging a patient, supporting others. We have a brand new adolescent unit at our hospital, and we've learned a lot from our veteran nursing staff and veteran physicians about how to best deal with the unpredictable, especially over the pandemic. But certainly witnessing self-harm behaviors and worries about unpredictable patients who might put others at risk is always very stressful.
Mm-hmm. Thanks for providing that experience or that perspective on the hospital staff experience. All right, so I'm mindful of time. I'm going to ask Malka to share a little bit about resilience factors for people with psychosis and trauma.
Okay, I'll try to be brief. But just like we talked about risk factors for the development of PTSD following psychosis, then we're going to talk about some resilience factors. So things that make it less likely for someone to develop PTSD following psychosis. So again, social support, I think it's clear that that's a really big one and really important one. So trying to engage social relationships as much as possible, adapting coping skills. So there's a whole bunch of things that can fall under the category of adaptive coping skills, such as being able to problem solve, right? Like look at a situation and see what resources do I have available? What steps can I take to make this better? Use of emotional support. So bringing in loved ones, drawing on loved ones, speaking to them, getting their support, use of instrumental support. So whatever resources that are available out there, if it's a therapist or a clinic or a website, anything that might be helpful for this person who is struggling, to be able to draw on those things. Religion, humor, all of these things can be adaptive coping skills. Optimism has been found to be an important resilience factor. So someone who is more likely to think about or visualize a positive outcome over a negative outcome is less likely to develop the PTSD. Trait resilience. So this is kind of like some people have that natural ability to bounce back, kind of what we talked about earlier. And so if someone does have that more natural, which can be fostered, right, in childhood, but if an individual does have that trait resilience, they're more likely to bounce back from the psychosis and the trauma. And then self-efficacy is the ability that I can get through this. I can handle this challenge, and I have the resources I need to get through this. And lastly, secure attachment. So feeling like I have people who really care about me, people who are really there for me, that I don't have to be worried whether or not they're going to show up for me when I need them, is another important resilience factor.
Awesome. Thanks, Malka. All right, I'm going to skip a couple of slides just so that Pamela, if you would share some aspects of a case of someone who, a case vignette of someone impacted by psychosis spectrum disorder.
Yeah, absolutely. So I think we care about this stuff in the abstract, but also really important to bring real life implications to the stuff we're talking about. So I'm just going to briefly highlight the summaries of a vignette of a client who is a 23-year-old Black Latino gender non-binary individual who's currently enrolled in grad school. They have significant past history of mental health concerns, including depression, prior suicidal ideation attempts, and chronic general and social anxiety since adolescence, in addition to experiencing auditory and visual hallucinations, primary voices saying negative or critical things about them, and general feelings of vague suspiciousness or paranoia about others, which began in early adulthood. And despite receiving financial and practical support from their parents, they report a family culture growing up that was stigmatizing of mental illness and perceived mental distress, and currently sure that they're not particularly close with parents. However, they have a very supportive social network of peers and close friends. And Darius has been in care with an early psychosis specialty team, for 1.5 years.
15 minutes remaining, excuse me.
Oh, thank you for that reminder. I'll read faster. and have a collaborative and supportive team, and experienced quite a significant amount of relief from these symptoms. However, during a particularly stressful semester, when they caught the flu and fell behind during a critical time in school, they experienced a flare-up and had increased symptoms of hallucinations, depression, and suicidal ideation. And Darius decided to go to the emergency room to consider inpatient hospitalization for their concerns. Due to COVID protocols, they were stuck waiting for a bed in the emergency room for 3 days, during which their phone was taken away. They had to wear uncomfortable or pajama-like clothes all day. They had to remain isolated for 2 days while they were COVID tested. And because they were an adult, their parents were not contacted about their hospitalization and didn't know what was going on until after discharge. And after spending 3 days in the ER, Darius decided to return home rather than proceeding with inpatient hospitalization stay. And after meeting with their therapist upon discharge, they reported feeling overwhelmed at the thought of catching up on all of the schoolwork that they had missed, and reported saying that they were doomed to fail the semester no matter what. And so this is a vignette or example drawing from different clients and folks we've all seen in the past, and experiences that folks have had utilizing crisis care, both before and during the pandemic. So I invite folks to think about, consider, and share in the chat as they feel comfortable a few different responses to the ideas about what were the risk factors for Darius to develop PTSD or trauma-like responses to crisis care utilization. And what are some resilience or protective factors for Darius? And also maybe what would you do differently to better support Darius? So I know that's a lot of content. Let it percolate, sit, spend some time typing, and share with us any or all responses to those questions.
You know, Pamela, there's so much information in that case, but I feel like it's so hard to move past the 3 days in the ER. And I feel like if we just had people put in the chat the number, we, see what's the longest somebody's been in the ER. We've had patients for weeks in the ER sometimes, especially during the height of the pandemic shutdown. And it's really unfortunate that somebody during a crisis episode is stuck in that setting, which is extremely stressful to be in, even though it's designed to be quite therapeutic.
Yeah, absolutely. I think it's one of those kind of risk factors that also can confer multiple different risks, both of that isolation, not being able to interact with folks or get social support, even from folks on the unit, and kind of being stuck in that limbo space can be really hard, particularly when folks are at a crisis. And as you alluded to earlier, being separated from cell phones, being away from the things that connect us to the things we care about, I think can be quite hard as well.
Yeah, I mean, I'll try to get the ball rolling. I really think as a mental health provider, but as a parent, there's nothing that replaces the in-person support. And so we've learned from the pandemic, we're not prepared for these kinds of restrictive situations, but also that young adults, because of consent issues, it can be challenging about who's allowed in. So thinking about how the hospital system can help provide that in-person, one-on-one support for folks who don't have it, and then what's the way to keep people connected with who's important to them while they're in the emergency room. 3 days is a long time. That's a long time.
Yeah, I see someone kindly shared some information in the chat saying that they know someone who had a hospital stay of 3 months due to a psychotic episode. So not only can folks be stuck in that kind of ER space for quite a while, but hospitalization can last for quite a long time. And that can disrupt a lot of different things that can lead to being a risk factor for the development of PTSD around crisis care. So thank you so much to one of our audience members for sharing.
Thank you, Pamela, and audience members for your comments. And I'm mindful of time, and I want to continue to engage the audience, especially around the questions here that are really important for us in our process of thinking about prevention of PTSD for folks impacted by psychosis spectrum disorders. So if the audience would share some of your reflections on these questions. What are some unmet patient and or family needs related to PTSD prevention during crisis care? And what types of support would be helpful after hospitalization to prevent PTSD? Please share your reflections to these questions in the chat box.
I would like to add, dream big. What are we not doing that we should be doing? So this panel is full of young people who have great ambition to try to get funding and to design new strategies. So help us think big and what would make things better. I did want to mention, related to the case, one of the things that we've tried doing in our hospital system that seems to be well received is in the case Pamela mentioned about the school stress. And we found just that transition back to school is an incredible mountain to climb for a lot of patients. And I'm sure the same in transitioning back to work or any kind of vocational training setting. And we found that having a dedicated resource for school transition that helps them beyond the day of discharge is really helpful.
While folks are thinking and typing, I can also share that clients and families have also discussed this topic with me, and I think just information not only about what's going on, but also about the process of hospitalization can be really useful, and that can feel like folks are really powerless if they don't know what's going on. So being mindful of making space and time and educating folks and doing so in a way that doesn't feel overwhelming, like a huge written pamphlet, can be really helpful for letting folks know what's going on. I also see someone who is responding, so I just want to share things from the chat, that it's someone saying that folks went through a house fire and definitely needs more counseling or use of peer support recovery specialists to help support dual diagnosis or co-occurring disorders. So that kind of extra support. Another person says, how about a branch or a person from the crisis response team to show up in the ER to talk with, bring water, contact parents as they interact with patients or clients. Another thought, maybe more for veterans before leaving service, especially females. So a lot of great ideas being shared in the chat.
Yes, thank you for sharing those ideas, and please keep those ideas coming, and also feel welcome to reach out to us via email. If my co-presenters can put our email addresses in the chat box. We really do want to hear about your reflections on these questions, as it'll be very, very helpful for us in our process of developing PTSD prevention programming for this population. And I'm just going to quickly highlight some existing PTSD prevention strategies. I'm going to name them high level, and you will get a copy of these slides, so you won't miss anything here. Just highlighting that prolonged exposure treatment that involves imaginal exposure, processing of the trauma memory, and in vivo and imaginal exposure homework is associated with decreases in depression. Just one session is. And lower trauma severity for folks experiencing trauma symptoms. And then cognitive behavioral therapy interventions that involve education, relaxation, imaginal exposure, cognitive restructuring of fear-related beliefs, and in vivo exposure are associated with reductions in PTSD symptoms compared to supportive counseling and self-help booklets. And then the final strategy I wanted to lift up is collaborative care interventions that include post-trauma case management, motivational interviewing that target substance and alcohol use, and medication and or cognitive behavioral therapy for PTSD. In comparison to usual care, this collaborative care type of intervention is associated with decreased PTSD symptoms and improved functioning for folks. And I think we only have about 5 minutes left. We have a slide on drug treatment options for PTSD, and I invite Gloria to reflect on that.
So a lot of A lot of people ask about medications, or we get a lot of questions about things like medical marijuana or alternative treatments. We know for adolescents, there's no anti-PTSD drug. There's nothing the FDA has told us it's got great effectiveness and safety in teenagers. So the first line treatment for PTSD, both prevention and intervention, is really using trauma-informed therapies. We know in adults, sometimes antidepressant medications are used. I think on this, it says TCS, but usually SSRIs are kind of a first-line medication. We're still learning about lots of different alternative therapies. I worry a lot about things like medical marijuana and developing brain, because we know that individuals who have a vulnerability to psychosis can be at greater risk for those kinds of problems.
Thanks, Gloria. And then I'll just share lastly on this one slide about what supporting a loved one impacted by trauma, what that can look like in a helpful way. So supporting engagement in enjoyable activities, offering up whenever possible to go to doctor or therapy appointments with a loved one, to share important information that they may have forgot about their experience or symptoms or needs. Learning to recognize trauma triggers and supporting your loved one with coping with triggers, and then checking in regularly with your loved one to offer support, engage in activities for joy, and encourage them. I also just wanted to share a few resources that offer up practical tips for both providers and families and loved ones. There's a trauma fact sheet for families, responding to loved one with psychosis blog by NAMI, and then suicide risk practices and care transitions for those working with folks transitioning from inpatient to community care. And then I think we still have about 3 minutes to answer any audience questions, and some selected references, and thanks to you all for to both my co-presenters and the audience for engaging in this conversation today. And I'll stop sharing my slides.
Thank you. Thank you. That was really wonderful, very informative. We appreciate each and every one of you. I put in the chat an email address for participants if you didn't have a chance to ask a question or get your question answered. We just want to thank everyone and hope you enjoyed today's very important workshop. Are there any final statements that any of the panelists would like to share before we close out? We have a couple of minutes.
Just you can hear the love and compassion in the chat about people sharing their own experiences with family members, and I would say don't give up. It does make a big difference, and one of the biggest challenges we've had over the pandemic is staying connected and being supportive of one another. So don't give up. It's a wonderful thing to support a family member and to support ourselves and get well.
Absolutely. And I see a request for the resources, and I can populate the links to these resources in the chat box. Oh, I don't know if it'll give me all of them. So I'll do that right now. And also feel free to reach out to us if you have resource requests. Maybe I need to stop sharing. Okay, let's try that now.
Okay, thank you, everyone. Take care.